to you all that it's really a privilege from India and Bangladesh to address the world today on a topic which is very near to our heart, renal replacement therapy that is being done in the intensive care. And since the replacement therapy, that's dialysis that came into vogue way back in 1940s, and when Dr. William Kellum from Netherlands, he started the first dialysis, and in 1943, he unknowingly did a dialysis for around 11 hours on a 67-year-old woman, and she survived. And that was one of the first prolonged dialysis that was done in his critically ill patient. And from then, slowly we improved on our machines, our techniques, and initially we used to use an arteriovenous line, and now we have moved into the veno-venous pattern of dialysis, and from intermittent hemodialysis to sustained low efficiency daily dialysis and to continuous therapies for 24 hours. So our aim today is to discuss the whole of renal replacement, especially the continuous renal replacement therapy, dedicated to all the intensivists who are participating today, and to make them and to assure them and to reiterate that yes, we intensivists can do this continuous therapies. Definitely, we may need sometimes the help of our nephrology colleagues, but for the continuous renal replacement therapy, the nephrologist can take the decision, can start, can put the lines, and we can proceed accordingly. Today, I have with me a galaxy of my colleagues. The whole of them are very learned. Most of them, all of them, in fact, are part of the renal replacement guidelines that are coming up, the white paper that is coming up by the Indian Society of Critical Care Medicine. And I also have the privilege to introduce, I'll introduce them one by one when they speak. And I leave the platform to Dr. Lopa, Hasina Jahan Lopa, who is a chief intensivist of Shamonita Medical College and Hospital in Dhaka, and she's involved with us for the last couple of years in not only in renal replacement therapy, but also every aspect of intensive care. And she's very enthusiastic, young, agile, and I hope that she takes from here and she introduces the first speaker.
Thank you very much, Dr. Ranajit. First of all, I would like to take the opportunity to give thanks to Dr. Sa and that it's a continuous academic and scientific program he's doing, and his dedication is really appreciable. And in such a wonderful platform, actually, renowned intensivists from across the world, actually, we all are together for MEGA. So congratulations, Saad, for a series of symposiums. It's only possible for MEGA. And today I'm excited actually because this is very close to heart that Ranajit told, that a renal symposium. The speakers today, we all are here, and actually who really work very close to the CRRT. I know Dr. Ranajit because he is dedicated, and Dr. Vivek, Binay, Dr. Abhishek, and all are dedicated to CRRT. So I think today it's a very excellent symposium for all of us. Dr. Sharmili is also with us, and we are recently we are working with the RRT white paper. Now I think this is also our great opportunity to work in this type of work actually. So today our first speaker is Dr. Sharmili Sinha. She is senior consultant in Apollo hospitals from Bhubaneswar, and she is a very dedicated intensivist. And not only, I also want to add something about her. She is recently she is working in newsletter from critical care communication from the ICCM journal, and she is an associate editor of the newsletter, and she is working in ICCM and also across the world. Lots of webinars she is doing, and she is also interested in CRRT. So today our first speaker is Dr. Sharmili Sinha. So welcome, Dr. Sharmili.
Thank you very much, Dr. Lopa, for this nice and kind words of appreciations. And once again, big congratulations to Dr. Saad and Team Mega for their continuing academic endeavors. And I'm so happy to be, sharing the platform today with the eminent intensivist with the special interest in critical care nephrology and renal replacement therapy. As all of you have mentioned rightly at the beginning, that kidney injury and critical care nephrology are part and parcel of therapy in critical care units. And it is one of the important aspects of these patients in ICU that is gaining more and more prominence across the world. And intensivists are actually gaining more role to play in the management of such patients in the ICU. So here in the series of talks or symposium, I have the first topic on introducing our introduction about acute kidney injury. So let's go through it. So what is acute kidney injury? It is actually, as any syndrome happens, as it's sepsis, as you say, or it is acute kidney injury, it is a syndrome. It is just not on one single organ which is affected. It is actually a syndrome which affects multiple organs across the body. And it is very, one of the common words which is being, or descriptions which is being used these days is organ crosstalk. So let's start with a clinical scenario, because all of you are, we are clinical intensivists and you love discussing cases all the time. So let me present these two real cases which have been recently treated in our unit. So this is a 42-year-old man who was recovering from traumatic brain injury in high dependency unit, that is the step down unit. Now on day 10 of his illness, he develops one spike of fever. He has reduced urine output in the last 3 hours, which the nurse reports to the doctor. There is an episode of now hypotension, right? And this patient is not on any antihypertensive drugs or traumatic brain injury patients are usually sometimes prescribed anti-edema agents like mannitol or other kind of diuretics to reduce the brain edema. So this was not present in this case. Now the last total leukocyte count done 3 days ago was normal. There is an indwelling urine catheter which is 12 days old. And when the duty doctor asked for blood gas, they found there is metabolic acidosis with high lactate around 3.2, and potassium is already raised. There is hyperkalemia, which was previously normal, up to 6.7, and now liver function is normal. So what will be the suspected diagnosis in this case? So given this scenario of the sequence of events, the most common diagnosis which comes to mind is an urinary tract infections, and probably the kidney function is impaired. So we'll go about it, as we subsequently discuss the slides. Just keep this scenario in your mind. And most commonly, we end up assessing the renal function test like urea, creatinine, and the electrolytes. And probably we'll also work up this patient for sepsis. We'll discuss this in detail later on. Now, another case is a bit different. He's an alcoholic and he was suffering from acute severe necrotizing pancreatitis. In the initial days, he had recovered from acute kidney injury. Now on day 35, that is almost past 1 month, he had new onset of fever and urine culture grew multi-drug resistant Klebsiella, which was sensitive only to colistin. Now creatinine is very slowly, steadily jumping from 0.65 to, just crossing 1 and touching 1.36. When we started again worrying about his renal functions and the drugs. Now urine output is marginally reduced. Now here the question crops up in our mind is, now do we need to reduce the dose of colistin, because it's obviously known nephrotoxic drug, but also we are worried about the multi-drug resistant Klebsiella infections.
Yes, visible.
Okay. Visible. Sorry for this inconvenience. So good.
Sharmili, please go to the previous slide because that was not being. Yes, from here, from creatinine, you go on after that as the creatinine is jumping, they will continue.
So urine output was also marginally reduced. So the question which crops up in our mind is like, do you need to really, address the dose of colistin? Because colistin is a known nephrotoxic drug. And of course, at this stage, because the patient had an episode of AKI earlier, we were wondering if you didn't need to reduce the dose of colistin. So these are the kind of scenarios where we have to, at least think about the status of the kidney functions. Most of the cases, it is best recommended to preempt decline in kidney functions, or at least early diagnosing the acute kidney injuries, so as to manipulate or readjust the therapy in these cases. So acute kidney injury is a syndrome, as we discussed at the beginning, and it has a broad range of etiologies, starting from pre-renal, renal to post-renal causes. And in the intensive care unit, we mostly come across pre-renal and renal causes. And one of the commonest being sepsis, of course, and the incidence could be as high as up to 31%. So if you have 10 patients in the intensive care unit, at least 3 of them are highly likely to have or the incidence is at least, 3 of them have got acute kidney injuries. So, and a good chunk of them actually also proceed to develop chronic kidney disease or end-stage renal disease dependent on dialysis. So it adds huge morbidity and financial burden to the societies and to the patients. And also, similarly, as we said, because there is an organ cross-talk syndrome or processes in place, they also end up with developing cardiovascular diseases, sorry, or congestive heart failures. So I actually call it, the most common, we are all familiar with the term that is cardiorenal syndromes. I call it also renocardiac syndrome, because patients who have got AKI or who subsequently developing chronic kidney diseases also tend to have impact on the heart due to the kidney injury per se. So obviously the short and long-term mortality remains high, and those requiring AKI dialysis, mortality could be as high as 80%. And diagnosis delay is actually also reported in cases up to 40. So for all this reason, we need a good monitoring tool, and it is very essential that we at least preempt. And if these patients develop acute kidney injuries, we must have some tools or assessment methods to early assess the decline in the renal functions, so that accordingly we can plan our preventive and early therapeutic interventions. Now coming to the much discussed classifications of acute kidney injury. Now this is something, as Dr. Ranajit mentioned at the beginning, that it has been evolving for over the last 3 to 4 decades. And since we were postgraduates, we have been hearing about this classification methods. The earliest one was the rifle. It has got 5 components. As you see, each of these stands for risk, R for risk, then injury, then comes failure. And at the end, when there is need for renal replacement therapy for more than 4 weeks, it becomes loss of kidney functions. And at the end stage is when there is continuous need for more than 3 months. First one, I would say, first and second one are more important, because these are the initial stages where the patient, is just in the process of developing renal injury. And you see, it is usually characterized by an increase in the serum creatinine by 50 to 99%, or urine output is slightly declined less than 0.5 ml per kg per hour for up to 12 hours. And then comes the second stage, that is the injury stage, where it has almost doubled the creatinine, or the urine output is less than 0.5 ml per kg per hour for up to 24 hours, and subsequently it is followed. Then came the AKI classification, and it was not very popular because, rifle and AKI were almost, there were slight differences. And the most common one, which is being followed nowadays, or, easily understood and practiced across the world, is the KDIGO classification. So KDIGO classification, you see it is an increase in the serum creatinine in the stage 1 by more than 0.3. I repeat, it is 0.3 milligram per deciliter, or there is an increase, say, up to 99% from the baseline creatinine level, or urine output is less than 0.5 ml per kg per hour for 6 to 12 hours. Now in the stage 2, the urine output criteria is less for up to 24 hours, and the jump in creatinine is up almost by 100%. Now in the stage 3, increase in serum creatinine is more than 200%. Or increase in serum creatinine is more than 0.3 to 4 milligram %. Or the urine output is less than 0.3 ml per kg per hour for more than 24 hours, or there is complete anuria, asking for renal replacement therapy. So now that we have seen this major three classifications, very often, I would say for my junior colleagues and even for senior intensivists, many times it crosses their mind, like how often does this above classification help? I would say actually we must put these classifications or use this classification in the context of a clinical scenario, right? And most common traditional ways are to, to direct the assessment and therapy based on urine output and the renal function test, which includes blood urea or creatinine estimations, creatinine clearance, and urine routine microscopy. So this is something that we have already discussed. I just like to highlight that urine output criteria, because it is something gross. It is visible to the eyes, and even the bedside nurse or the junior doctor can report this. This is usually highly sensitive marker. And once it has come to the stage of oliguria and progressing further, this urine output becomes also has got high specificity in indicating onset of acute kidney injury. But remember, by then it has already gone to the higher level or higher stage. We have already discussed this. So now what are the pitfalls in the definitions of acute kidney injury? Because the three major components that we discussed, one is the creatinine estimation, one is the urine output, and of these actually so many times we combine to derive GFR. GFR stands for glomerular filtration rate. So what are the fallacies in the estimation or the assessment of these three main parameters? I would say just let's address urine output first. Now, urine output is a gross thing. It is being drained through a pipe and it is being collected in a urometer bag by the patient's bedside. So it's a good and early marker of decline in kidney functions. But there are difficulties in urine collection data. And many times in these patients who have got multiple organ issues, they receive diuretics. So it is difficult to understand like how much the patient urine is being produced due to the intact or preserved kidney function, and how much is due to the effect of drug diuretics if they're on these medicines. Because suppose a patient who has got traumatic brain injuries, they receive say drugs like mannitol or sometimes furosemide also. And if urine output is preserved in them, it will be difficult to assess or preempt decline in renal functions only if you're looking at the urine output, because they also may be developing impairment in the kidney functions due to a variety of causes. But if you're only following urine output, the early decline in kidney function may be missed. So this is the point that we are trying to make here. And many times there are mechanical causes like catheter-related issues like leak. If the balloon is not well inflated, that could be leak around the catheter, and actually urine which is being collected in the bag may be less. And there are instances where catheter has been obstructed, is blocked, and the nurse reports to you that there has been decline in the urine output. And the moment you flush the catheter, urine output improves. So there are fallacies in collection of the data regarding the urine output on a daily basis. Now, urine microscopy. It is a very common test and it is easily performed. The report is usually obtained within a few hours. The common things which when you look at these patients in ICU are the proteins. Now, proteins could be either single plus or double plus depending on the patient's baseline nephropathy present or not, or if there is new onset of kidney injuries. RBCs may be present or may be absent, and if persons are usually more than 6 to 8 in a urine sample, it is presumed that or indicator of urinary tract infections. That could be sediments, have a nitrite. Nitrite, if it is present, usually it indicates there is some infection may be present. And many of those emergency units or intensive care units have got some dipstick methods to test for nitrite and give treatment for urinary tract infections. Bacteria you can however see only through the microscope. So a urine microscopy gives some insight, but not overall reflection of kidney function per se. Now let's look at this renal function test. Blood urea is one of the components of it, and it has also got its limitations, that it could be falsely raised in patients who take or who are on high protein diet, like who are mainly taking meat, etc. Those who are on continuous glucocorticoids. If there are instances of tissue breakdown for patients who have been on chemotherapeutic agents, also it could be falsely raised without actually affecting the renal parenchymal functions or the tubular functions. Patients who have got liver patients, chronic liver disease patients, if they have GI bleed, also urea could be falsely elevated. It could be falsely low as well for patients who have got poor nutrition or those who have chronic liver disease with compromised liver functions, because urea is produced in the liver cells. And if it is really this function is compromised, the level of urea in the blood could be low, even with a compromised renal function. So what about serum creatinine? It also has got a very poor correlation with the glomerular filtration rate during a dynamic state. Why so? Because there is a variability in its productions. And we must recollect our or recapitulate our physiology base, where we have read that there are extrarenal sites where creatinine is produced. And there is tubular secretions, renal tubular secretion up to 10 to 40% in the proximal tubules. So it's not a real-time biomarker, but it may not significantly rise till there is already advanced compromise in the renal function has already happened. So in this process, we miss the therapeutic window. So summarily, the creatinine may remain normal, but kidney impairment or injury might have started. So by the time actually creatinine jumps to a higher level, significant damage in the renal function might have happened. In the process, also we do calculate creatinine clearance sometimes in the intensive care units to adjust many doses of drugs levels. And but it is also not ideal because it has its own fallacies. See, regarding the GFR measurements, because there is no exact correlation between the loss of nephron and the loss of GFR. As we just discussed, that kidney actually adapts to the loss of some of the nephrons by compensatory hyperfiltration initially, or by increasing the solute and water reabsorptions in the remaining normal nephrons. You see, this is a graph which depicts serum creatinine and the GFR relation. This is the GFR and this is the serum creatinine. So up till almost normal GFR is up to 100, 110, 120 ml per minute. Up till 60, that is up till 50% of decline in the GFR, creatinine is almost preserved. And thereafter, it tends to offshoot sharply. So by the time you see a sharp jump in the creatinine level, kidney function might have been affected more than 50% already. So one cannot rely on creatinine alone for estimating or monitoring the renal functions. And also you'd be surprised to know that there's a very odd relation between serum creatinine and GFR. Actually, in mild kidney disease, when there is a small rise in serum creatinine, it actually indicates a marked fall in the GFR. While in advanced kidney disease, when there is a marked rise in the serum creatinine, this actually reflects a small absolute reduction in the GFR. And in patients who have got advanced kidney failure, there are extrarenal creatinine elimination, mostly in the intestines due to presence of bacterial creatinase activity in the gut. So in patients who have got acute on kidney disease, so there's a term called acute on chronic kidney disease. So in those patients, actually serum creatinine will be lower than that would be expected from the calculated GFR when you're using the creatinine alone. So this is another graph which depicts the functional reserve of the kidney mass and the GFR relationship. So you see GFR is preserved till almost 60 to 70% of the functional reserve, and thereafter it tends to fall sharply. And as you saw in the previous graph, then the creatinine tends to shoot off sharply as well. How do we measure the creatinine clearance? It is mostly by measurement or calculation by some formulas, and also it is estimated in the laboratory by certain biochemical methods. But there are issues with the serum creatinine measurements in the laboratory, because the serum level can be affected by certain commonly used drugs in ICU, like the H2 blockers. Those are the famotidine or the ranitidine. These are the antacid drugs. Also, patients who have been on chemotherapy drugs, also level gets affected. And also there's this issues with the assay method. These are biochemical assay methods which are used to estimate the level of creatinine in the serum in the laboratories. So those are labs which use alkaline picrate method or colorimetric methods. It could vary from lab to lab. And also the methods like MDRD or this kind of methods which also vary from lab to lab. We'll not go into the details of this. Also might report different creatinine levels for one single sample when they are tested in different methods or in different labs when they are using different assay methods or even equipments. So these are the ones which we roughly discussed right now. And patients also, suppose post-op patients, many times patients who have got trauma or abdominal surgeries, in the immediate post-op period, they have a high increase in the level of ADH, that is antidiuretic hormone. So these patients also, due to pain, nausea, and these patients, there is increased absorption of the salt or volume. So they may falsely indicate decrease in the urine output and might cause this misdiagnosis of acute kidney injury. The rest of these things actually we just discussed in our previous slides. So how we go by for this creatinine clearance measurement or estimation by formulas? We have discussed this. That is, if you are using trying to measure this 24-hour urine collections, it can be affected by the use of drugs like this H2 antagonist or by tubular secretions of creatinine. But this is usually not practiced in our ICUs. And most of the ICUs, I do not think they use this method of 24-hour urine collection method for measurement of creatinine clearance. And actually, it is not useful in the setting of acute kidney injury because there could be a variety of factors or drugs which the patient might be on, and it will actually interfere with the estimation of the urine creatinine and then also the serum creatinine level. Some of the centers actually also have, this is a group of investigators from Australia where they looked at to, instead of 24-hour urine collection, if they can go for 4-hour urine collection and estimation of creatinine clearance. This is more useful in patients who have got on chemotherapeutic agents and malignancies, because in these patients, it becomes very important to adjust the doses of the chemotherapy drugs. But what they found is that this also can be utilized as an alternative for 24-hour urine collections, because 24 hours collecting the urine up to say 1.5 liters to 2 liters, it's a cumbersome method and it becomes difficult to collect, transport, and then estimate the creatinine level. So instead, you can go for this 4-hourly collection methods. So regarding the estimation equations, these are the common ones which are used in our practice. The common one, I think most of us are aware of this Cockcroft-Gault formula. The other one is the MDRD formula. That is just for the knowledge sake, we are mentioning this. We are not going to discuss this in detail. That is modification of diet in renal disease. The third one is the most common one, which is being used in clinical practice, is the CKD EPI formula. And this is actually available in a software in an app form or in the software method, where you can use it in the computer or even in the mobile these days. But there are limitations of these equations. Cockcroft-Gault formula, I think all of us know this. This is the formula. And for women, we have to multiply this by a factor of 0.85, but this is not adjusted for body surface area. You must note a limitation that creatinine clearance measured by this equation actually will result in a 10 to 40% overestimate of creatinine clearance. Though this is, many times in our postgraduate days, we used to use this formula, but nowadays the CKD EPI formula is the common one. Why? Because this includes people with a GFR, which who are having a GFR near or above 60 ml. And it has a similar performance to the MDRD study equation for people even with the lower levels of GFR. And this is commonly used to estimate the kidney functions for adjusting the drug doses. Limitations are far too many. Like for diabetic patients who have got a high GFR, this may not be useful. For specific ethnic groups, it is noted that again, it might have issues, either overestimation or underestimation of the creatinine clearance levels. For pregnant women, because they're hypervolemic already, serum creatinine is actually diluted, it could be falsely low. Those who have unusual body mass or body habitus, again, it might be affected. Patients who are morbidly obesity, because the fat to muscle ratio is altered, they also might have fallacious readings in these cases. So more accurate confirmatory methods will be required. We'll just quickly discuss about the role of biomarkers, because because of all these fallacies of this creatinine clearance estimation measurement or the formulas, in the last decades, actually, many biomarkers have emerged for the aid in the early diagnosis of acute kidney injuries. So just common ones, we'll just quickly read. These are the functional biomarkers, could be either a cystanin C. Around 5 to 6 years ago, I started using this, but it is not very specific, neither sensitive. Now, other ones are the urinary low molecular weight proteins, like they started analyzing urine for different molecules, which included alpha-1 microglobulin, beta-2 microglobulin, and many others. Now, some markers which are associated with cellular injury or stress-associated protein, like neutrophil gelatin-associated lipokylin, kidney injury molecular 1, which is known as KIM1 as well, or also liver type fatty acid binding protein, and few more. Urinary tubular enzymes also were being studied in this regard. And even an inflammatory mediator like interleukin 18 was also studied, but this is still experimental level. So of this, let's see where the evidence stands. This is a a table which depicts the summary of meta-analysis of all this renal biomarkers. They have looked at this neutrophil gelatinase lipokylin, and different studies have actually given different level of cutoff values. And this is one of the biggest limitations for these biomarkers. Kidney injury molecule, you see there is only one study on this. And regarding liver type fatty acid binding protein, also one study, and the levels are variable in urine. Of this, which is most commonly, accepted, and I think also is FDA approved now since 2014, is this TIMP, that is tissue inhibitor for metalloproteinase 2 and insulin-like growth factor binding protein 7. I would say just remember in short that is TIMP and IGF-7. So this combination is commercially, kits are available for as a biomarker to be used in urine sample, and the cutoff value is 0.3 to 1.07 nanogram per ml. And this is available in the commercial name of NephroCheck, and couple of centers it is available. This we have already discussed, and of this I would say this is TIMP2 and this IGF-B7. In short, remember this. This is to be sample is the urine, and it's an immunoassay method. Cystatin C was used 4 or 5 years ago. It is still sporadically used by some of the clinicians, but it is not specific, neither sensitive. And these molecules like KIM1, that is kidney injury molecule 1, or LFABP, these are not regularly used or not recommended. So I've shown this. The cutoff value is 0.3 nanogram, which is the low limit. It is US approved since 2014. Now, what is the relevance or usefulness of this biomarkers in the definition of AKI? See, we discussed about mainly 3 stages of rifle or this KDIGO. This initial is 3 stages. In the first stage, actually, it is single plus. Now, when the kidney injury progresses in stage 2 and subsequently it becomes more sensitive and specific, it leads to double plus and triple plus. So I would rather emphasize it is the first or second stage where the biomarker, if at all, has a greater role to play, because subsequently once your creatinine is obviously rising, urine output is obviously decreasing according to those cutoff marks, and it is very obvious. So there probably you do not need the help of a biomarker to diagnose, but it is the early situation or in the preemptive when you are actually started suspecting these cases, there is the role of biomarkers. So you can stratify the risk factors like low, moderate, medium to very high risk cases, and it is in the medium to high risk cases that one should go for the measurement of biomarkers. And in very high risk cases, it's probably not useful already. If it has already set in, you would rather go for preventive measures or nephrology consultation and do the needful. So literature it is heterogeneity of the studies are there, different cutoff values, and immediate extrapolation of the data to clinical practice. Like suppose you're finding it immunities plus in the advanced stages, it does not change management. So it is the early stage where it has definitely an important role to play. But the issues are regarding cost, because the cost is very high and prognostic value is not much. So now coming back to the case 1, I would like to have a poll for opinion from the audience regarding the same case where the 42-year-old man was recovering from traumatic brain injury in HTU. He develops fever, hypotension, low urine output, and has a metabolic acidosis with hyperkalemia. So how will you examine his renal function? So of these 4 options, most appropriate step. Dr. Saad, can you go for the polling here? Questions at the end. So I think most participants have gone for option A, that is urine microscopy, routine urine and blood cultures and renal biomarkers at the outset. How it is going on? And hold on.
It is the highest answer question now, option 1.
Option 1, yeah.
Yeah.
I think most of all our colleagues are very smart, and they have gone for the most appropriate answer. I would say, obviously, developed acute kidney injury maybe in stage 2, but I would say this is, though it sounds appropriate at this point, like you can send the urine microscopy. Obviously, the cultures have to be sent because it is sepsis. And biomarkers, I would say it is a plus minus at this stage, because this patient has got low urine output, has metabolic acidosis is set in with hyperkalemia. So this patients, you can send renal biomarkers, but if your setup do not have facilities for estimating renal biomarkers, only sending the cultures and microscopy at this point will also suffice. But most appropriate step obviously is the answer A. So I think we have gone for the second poll.
We can share it now.
So I think, yeah, how can we stop here? I don't know. I mean,
yeah, okay.
Okay. I think we'll give 1 minute, so that is adequate. So I think the so option B and D are almost competitive, equal. 38% say that they want to go for option B. That is, let me close this. They want to go for option B, which says biomarkers should be done daily for prognosis in cases of AKI, followed by 35% who say that renal biomarker and procalcitonin together is more useful. I think this is a bit difficult question compared to the first one. So this patient had already recovered from one incident episode of AKI earlier, and he has got a very difficult to treat MDR Klebsiella infection in the urine. He's febrile, he's symptomatic. So we have to give colistin, because polymyxin is not excreted in urine. Hence, we cannot use that molecule. We have to use colistin. So in these cases, on the day 1, his creatinine was normal, and we were obviously, prompted or wanted to give him the full dose of colistin. It would make sense do a level of renal biomarkers at the outset to know that where we stand. At least this nephro check or that TIMP or IGF combination, one must do. But I am sorry to say that there is no literature evidence so far to which indicates that biomarker or renal biomarkers should be daily done on daily basis for prognosticating cases of acute kidney injury. So option B is actually not true. And option D, that you can say renal biomarkers and procalcitonin together is more useful. Procalcitonin obviously is an infection marker of sepsis, and it has a role in de-escalation of antibiotics, but doing together renal biomarkers and procalcitonin is also not proven more useful compared to the conventional management. So in this case, actually, option A would be the most appropriate answer on day 1, when we are had double minds if to stop or reduce the dose of colistin or to continue with the full dose of colistin, at least for initial couple of days. So I think that was, we can discuss, take questions on that. And just quickly, I want to point out from my clinical experience about the common nephrotoxic drugs, which are used in ICU and are very commonly responsible for increasing the incidence of acute kidney injury in ICU. Most common at the top in the list is analgesics or the non-steroidal anti-inflammatory drugs, which are also being commonly abused in the community, and also when they come to ICU, especially for post-operative patients, certain surgeons have inclination for using these drugs, and because they are strong analgesics. But nevertheless, for patients who are older than 60, have got multiple comorbidities, these are definitely very dangerous and highly likely to precipitate acute kidney injuries. Antibiotics commonly used in our ICUs. Aminoglycoside is commonly known as a nephrotoxic drug. Colistin also has got nephrotoxic potential, and it becomes a clinical challenge many a times for using this drug when you have resistant organisms, as you saw in the last case, and patient have mild, impaired kidney functions, whether to use this molecule or not. Penicillin, regarding penicillin, which is a very common molecule, has been there for more than 3-4 decades, is also has got nephrotoxic potential. Both penicillin and cephalosporin are known to cause a form of kidney injury known as interstitial nephritis. And when you're using this drugs for a long period of time, many times you see patients do not have any other risk factors, but they start developing acute kidney injuries. And if you look at the drug list, you see this antibiotics as benign as penicillin also can cause acute interstitial nephritis. Using albumin in patients who have got borderline renal function is also has got definitely a propensity for further deteriorating the renal functions. Now, the most innocent drug, which is very commonly prescribed in our intensive care unit, is the pantoprazole. And I think in discussion that the nephrology colleagues especially have been making a noise that pantoprazole is nephrotoxic. It also causes interstitial nephritis and also magnesium deficiency. And I think now officially pantoprazole has been branded as a drug which can cause nephrotoxicity. So the take-home points to summarize are to remember that AKI is a syndrome. So know your patients well, know all the risk factors, because once a patient comes to the ICU, they usually have may come with one single organ, but in no time they might go into have multi-organ dysfunctions at least. And once AKI sets in, it becomes a vicious cycle. Conventional blood tests like blood urea, creatinine are not the best indicators for assessing renal functions. We can take help of renal biomarkers in certain clinical challenging situations like our second case. Biomarkers like DIMP and IGF can be utilized for early detection of AKI in patients who have got multiple risk factors and clinical challenging situations. And judicious and frequent review of potential nephrotoxic drugs like say simple drugs like penicillin or antacids or even analgesics should be done in critically ill patients, because prevention is always better than cure, and safety and efficacy among resource limitations should be our goal. Thank you very much for your kind attention.
Yes, Lopa, you continue.
Yeah, thank you, Dr. Sharmili, for your excellent lecture. And I think it's a very lively, interactive session. And there are some questions. Actually, this is I think we have lots of lectures now. We have to go, but I think we should make it short. So there is a question that is, in cardiorenal syndrome, which side would you take, cardiac side or kidney side?
Very difficult question. So usually when they come, usually we see cardiorenal syndrome in cases in patients who have got compromised cardiac function already. It is there. And as a consequence of that, patient lands up with because it is organs crosstalk. In whatever disease you speak about, organs crosstalk, do crosstalk. And cardiorenal syndrome is a consequence of the cardiac dysfunction which is already pre-existing. So I would actually take sides of both and try to balance it as much as possible, because obviously you cannot sacrifice the heart for the kidney and you cannot sacrifice the kidney for the heart. So it's a matter of delicately balanced. But having said that, it's a challenging situations. But many times if you're just judiciously adjusting their fluid intake, giving sometimes the positive pressures for their cardiorespiratory support, many times they just require some BiPAP or a CPAP even to facilitate the breathing and reducing the work of breathing in these cases, and avoiding the further risk factors like avoiding this nephrotoxic drugs, adjusting their diets, and with judicious and delicate monitoring, we can manage these patients. But nevertheless, once the cardiorenal syndrome has set in, chances of mortality increases in critically ill patients.
Yeah, thanks for your answer. There is another question. Among us, the host of different biomarkers of AKI as discussed, which one can reliably and fairly accurately predict AKI early?
Yeah, that's the thing. I think last 3 slides were dedicated to that. So that is the TIMP, that is tissue injury metalloproteinase and IGF-7, protein 7 combination that is available with the commercial brand of NephroCheck. This is something which you can use on a urine sample also. In the initial stages, it has got good acceptable specificity and sensitivity, and it has been also FDA approved since the year 2014. But the issue remains about the cost. Nevertheless, this is the best so far that we have in our basket.
Okay. So this is the bedside assessment of severity of AKI by renal angina index.
Say that again, sorry?
There's the bedside assessment of the severity of AKI by renal angina index. Actually, yeah, you said?
Yeah, this is something which you do not commonly do by the bedside, but I think it will be covered in our subsequent lectures. This is what I discussed was about the clinical diagnosis and by the blood investigations that we commonly do. But renal angina index commonly we do not follow in the critical care unit.
Okay, I think there is another question that I think that will be urine output. I think that we can go for the next lecture. And thank you, Sharmili.
I think, Dr. Lopa, can I answer this? Because I think this is a very important one. This is a very basic though, but very important. I'm glad this question was raised. It's a question, if I'm reading correctly, for patient with post-cardiac surgery, less than 0.5 ml is adequate or less than 0.8 ml per hour. I think this is the thing, 0.5 ml per hour is adequate. For a 60 kg patients, 30 ml per kg per hour, that is 0.5 ml per kg, is adequate. We do not have to raise our bar to 0.5 ml. Because if you see all the 3 classifications, be it rifle, Akin or the KDIGO, everywhere they have in the accepted urine output, which is acceptable or adequate, is 0.5. That is the cutoff. And I think that's very important for all our postgraduates and junior colleagues and our paramedics team to keep in mind. Thank you.
Yeah. So thank you, Sharmili, for your excellent session. So now I will go to Dr. Ranajit Chatterjee to introduce our next speaker. So over to you, Dr. Ranajit.
Well, thank you, Sharmili, for such a nice speech and talk on AKI. Just for the around 100 people have joined already. So I congratulate all of you to be with us today, and also Dr. Saad to make it so successful one. It's a short one. What I just want to comment on this speech is that, see, we should not, the main thing that Sharmili was trying to tell to us, everybody, that we should not ignore even a small change in serum creatinine. The rise of 0.3 milligram per DL is also considered to be one of the definitions of AKI. That means suppose you are 1.1 milligram per DL and you have moved up to 1.4 and above. That means your patient has already gone into the acute kidney injury, and maybe 50% of your kidney is already gone by that time, as serum creatinine rises very slowly. And we unfortunately do not have a very good biomarker to predict exactly when the patients are going into those problems. This is number one. Number two, I told Sharmili, I think she had the slide also, but she somehow didn't show it, about the furosemide stress test. Most of these patients, we by the bedside, it is a propensity of all the intensivists and the physicians. When the urine output is not coming, we start giving lot of furosemide. Furosemide, yes, it can be given. It is also, if you give furosemide, give only at a dose of 1 milligram per kg body weight when the criteria of AKI is there, if your patient is not on previous diuretics. And see if in the next 2 hours, your urine output is going beyond 200 ml or not. If it is going beyond 200 ml, that means your patients are not going to proceed towards severe AKI. But if your patients are not having adequate urine output of more than 200 ml, your patient might be a patient who might be needing renal replacement therapy in the near future. So this is the use of furosemide. Yes, if your patient is already on furosemide therapy, use 1.5 milligram per kg body weight of furosemide. Regarding renal angina index, as Lopa was pointing out, yes, normally it is used in the pediatric patients. What basically they have given a scoring of less than 0.1 milligram per dl of rise in serum creatinine, more than 0.1, more than 0.3, and more than 0.4. 1, 2, 4, and 8 is the score. If the patient is in the ICU, they give a score of 1. If the patient is in diabetes mellitus, they give a score of 3. And if the patient is on ventilator, they give a score of 8. They multiply these two. Suppose you have a rise in serum creatinine of 0.3 and you are having diabetes mellitus. So your score is in 0.3 it is 4 into diabetes mellitus is 3. So 4 into 3 it is 12. So if the score is more than 8 by the bedside, these patients might be going towards severe acute renal injury. So this is basically a renal angina and use of renal angina index. Many people use, many people do not use. So the question was there, so I answered this one. And the third point that I want to mention to you is that the terminology AKI has just come recent, around the end of this century. Before that, we used to say acute renal failure. Now we say acute kidney injury, acute kidney disease, and chronic kidney disease. These are the three terminologies. Acute kidney injury, Lopa has told. Acute kidney disease is if the GFR is less than 60 ml per minute in 1.73 meter square of body area. And this is less than 3 months. And if it exceeds 3 months with some structural changes, that is chronic kidney disease. And all of this overlaps. So this overlapping of acute kidney injury, acute kidney disease, and chronic kidney disease has to be understood and has to be differentiated in intensive care. Just making this short comment.